Hi, is anyone here by any chance the meeting organizer? It won't let me share my screen to share my slides.
I don't think Megan is on or Saul. Danielle? Let me see
Okay,
if I can get a hold of someone.
sounds good. I'll just wait. Hopefully one of them will show up soon.
Danielle, do you want to just email me your slides? I'll see if I can share them. You might have to upload them on SharePoint to OneDrive and then be able to access them that way.
It currently says when it I can't even access the share button. It says only meeting organizers and presenters can share. But I'll email them to you. But
Yeah, let me just try. Hi, everyone. Thanks for joining. We're just having some technical difficulties and it's just 12:01, so give us 5 minutes to get started.
I just sent them.
Okay, I'm looking for them.
Megan, are you able to change a setting so that I can share my screen?
Sure. Yeah, sure. Let me go in and do that. If not, just email me them and I can also share them for you.
Sounds good. Okay. Megan, I've sent the slides. Let me know if you haven't gotten them.
Let me check, but I did update the settings, so let me know if you're
Oh,
able to share
perfect.
them.
Yes, it looks
If
like
not, I'll.
I'm able to share now. Let me just try that.
If you're unable to share, I have them and I can pull them up, no problem.
It doesn't seem to be working for me. It's if you don't mind just sharing them, sorry. Thank you. Let's see how many people are here. Should I get started or should I give it another minute or two to let everyone join?
I'd give it another minute, and then you can get started. It seems like more people are joining now.
So I think in the interest of time, we can get started. I'm just going to introduce Danielle for those of you who don't know her. It's Rena, the division head of ID. I just want to let people know that Danielle is one of our newest additions to the infectious disease division. We are so excited to have her on board. She's been working at SHN for the last 2 years, and many of you might know her for doing ID consultations at the Centenary site, both on the wards, and she is very focused in ICU and helping with our antibiotic stewardship and seeing patients who are critically ill. Her main focus outside of the ICU and ID consults has really been resident education, and she's our education lead for the ID division. So Danielle comes to us highly respected after doing her training at the University of Alberta for ID fellowship and McMaster for her medical school. Her focuses have been in the past women's health, HIV care, and as I mentioned, medical education and quality improvement. She's going to be working with our team on the Balance Plus trial. Many of you know the Balance trial that was just published in the New England Journal of Medicine, talking about using 7 days of antibiotics as opposed to 14. So the Balance Plus trial will be a collaborative effort with our ID ASP teams, Danielle and Ishwarya, looking at other issues related to antibiotic stewardship and use of antibiotics in sepsis. So with that, I will pass on the mic to Danielle to speak to you about some interesting ID cases and their management.
Hi, everyone. Thank you for that introduction. So as Rena mentioned, today I'm presenting on a series of some uncommon and hopefully interesting cases and a bit of teaching around all of them. So the first case is a serious case of sepsis. The patient is a 64-year-old female who was admitted to the ICU with profound hypotension requiring 3 vasopressors. She has a past medical history of osteoporosis, PCOS, and depression, and her meds are listed here. She lives independently with her husband and dog, is a retired nurse, and had not traveled recently. Next up, thanks. She presented with a 1-week history of influenza-like symptoms and a 1 to 2 day history of nausea and vomiting with progressive weakness. On the morning she was admitted, her husband called EMS because she was drowsy, confused, and extremely weak. She was found to be hypotensive, tachycardic, and hypoglycemic with a GCS of 13. She was admitted straight to ICU, where she was intubated and started on norepinephrine, vasopressin, and dobutamine. A septic workup was sent off, and she was started on empiric piptazo. On exam, she was afebrile, tachycardic at a rate of 120, hypotensive with a BP of 94/62 despite being on 3 pressors. She had a normal cardiac, respiratory, and abdominal exam with no focal signs of infection. She had cold, mottled upper and lower extremities, as well as her nose had become ischemic, and there was blood oozing from all of her lines and her OG tube. On investigations, her white count was elevated at 16.8, her hemoglobin was 66, and her platelets had decreased to 18. On peripheral blood smear, intracellular microorganisms were seen. She had a severe AKI and elevated liver enzymes and was quite acidotic with a lactate of 10.8. In terms of her cardiac workup, her CK and troponin were both elevated, as was her BNP at over 33,000. Her coagulation studies were in keeping with DIC, with a high INR and PTT and low fibrinogen. On ECG, she had a new left bundle branch block, and on TTE, she had an ejection fraction of 15 to 20% with severe global hypokinesis. Based on this information, ICU initially thought she could be presenting with cardiogenic shock. However, after speaking with cardiology, they did not feel that the changes were acute or consistent with an ACS. Her chest and abdominal x-rays, as well as abdominal ultrasound, showed no acute abnormalities. Okay, at this point in the case, does anyone have any thoughts as to what this could be? Feel free to unmute or type in the chat box if you have any thoughts. If not, we can move on. So we then found out after speaking with her husband that several days prior to admission, her new puppy had bitten her hand. Now with this information, does anyone have any guesses of what is causing this? Maybe one of our ID colleagues might have a thought.
So it's Rena.
Yes.
When you have an animal bite, you always worry about infections from the bacteria that are in the animal's mouth. So classically with dog bites, we worry about capnocytophaga, which is an encapsulated organism which can cause severe sepsis, especially in people who don't have a spleen.
Exactly. So Rena got it. Always an important thing, organism to keep in the back of our mind on medicine or in ICU, especially when patients are coming in very sick with no clear explanation. Something to keep in the back of our minds. Perfect. So at the lab called that she grew GNB in her blood cultures at 21.2 hours, and subsequently it did speciate to capnocytophagia canemorsis. So what is this bacteria? Just a quick little micro. It's a long, thin, fusiform GNB, as you can see in the picture. It does tend to be quite slow growing and typically takes up to 6 days to grow. But in this case, it was faster than usual. There are 3 species that are part of the commensal oral flora of dogs and cats, including C. canemorsis. There's also 6 other species that are part of the normal human oral flora. C. canemorsis does cause the majority of infections related to dog bites, and studies have shown that it's found in the oral flora of 67 to 86% of dogs and 55 to 84% of cats. So it is quite common, should always be thought of whenever there's a cat or dog bite. This is just quick history on it. So this was the first case report of capnocytophagia back in 1976. It had been previously undescribed. And this was a case of a patient presenting with sepsis and meningitis who had a history of alcohol abuse and had recently been bitten by 2 dogs. In terms of its epidemiology, it's quite rare and only causes 0.5 to 1 case per million people. 3/4 of infections are in men, and the peak incidence is in patients who are 50 to 70 years old. Interestingly, there's actually only a history of a known dog bite in about half of cases. There are some other cases that are associated with close contact with a dog or cat but no known bite, and in 30 to 40% of cases, the cause isn't clear. Lastly, about 2/3 of patients are immunocompromised. There are several risk factors for infection, including functional or anatomical asplenia, alcohol use disorder, cirrhosis, or immunosuppression from steroids or other medications. The patient in this case, though, didn't have any of these risk factors. C. cannomorsis infections can present as sepsis with bacteremia, which is the most common, followed by meningitis, which is the second most common presentation. Other presentations include infective endocarditis, cellulitis, pneumonia, ocular infections, and bone and joint infections. Patients often do not present with significant cellulitis around the dog bite, so it's important to ask about risk, like possible exposures. The typical period from a dog bite to symptom onset is typically around 5 days, and people typically present at day 7 to hospital. C. cannomorsis is associated with several severe complications, including DIC and gangrenous extremities, earlobes or nose, like our patient in this case has. Other possible complications include adrenal insufficiency secondary to bilateral adrenal hemorrhage, SJS, TENS, TTP, and HUS. It is associated with a high mortality of up to 30%. So moving on to treatment, it is typically susceptible to beta-lactamase inhibitors, third-generation cephalosporins, and carbapenems. Asplenic patients should be considered for prophylaxis after a dog bite with amoxiclav for 3 to 5 days. This is a case of a previously healthy 37-year-old male who was bitten by his dog and then developed capnocytophagia bacteremia. And in this case, he also had an elevated troponin and BNP, as well as mild ST elevation. On TTE, he had LV hypokinesis and a decreased EF. He was found to have myocarditis secondary to his infection, which was the first reported case in the literature. And given our patient's elevated cardiac markers, BNP, and similar echo findings, I wonder if she also had a similar case of myocarditis due to this infection. The patient's isolate was actually resistant to ceftriaxone, which is unusual, but was susceptible to meropenem, ciprofloxacin, and ampicillin. So she was transitioned to ampicillin and treated for 14 days. Any thoughts or questions about that case before I move on to the next one? Okay, so our second case is a curious case of chest pain. A 62-year-old male presented to hospital with progressive shortness of breath, chest pain, and a cough. In terms of his past medical history, he has HIV with a CD4 of 833 and an undetectable viral load, chronic hepatitis B, hypertension, and a history of cavitary lung disease. Next slide. His meds are listed here, and he had no known allergies. In terms of his social history, he smokes 1 pack per day, he injects both meth and opioids, and does not drink alcohol. He lives in an apartment alone, had previously spent 25 years in prison, and had a remote travel history only to the US and to Ecuador. On history, he reports that he was last well approximately 3 weeks ago. He initially developed orthostatic symptoms and shortness of breath, followed by rhinorrhea, pleuritic chest pain, and a productive cough around a week prior to presentation. He denied having fevers, chills, or night sweats, and had no history of trauma or any known sick contacts. On exam, he was afebrile with an elevated respirate of 40 and was satting 99% on 2 liters. His blood pressure was 111/79. His JVP was found to be 10 centimeters above the sternal angle, and he had quiet heart sounds. On blood work, he did not have a leukocytosis, and his creatinine was normal. CRP was elevated at 85, and his CD4 count had decreased significantly from 833 previously to 202. Here is his chest x-ray, and you can see what is called the water bottle sign on the left, which is when patients have an enlarged cardiac silhouette in a shape that resembles a water bottle. And this is typically found in patients with very large pericardial effusions. This is his CT chest, which, as you can see, also confirmed that he had a large pericardial effusion. I'm not sure if you're able to play the clips. If you hover near the bottom, they should. Oh, sorry. The next slide. Yeah. So these are just two short clips from his TTE, again showing his large pericardial effusion. And we can move to the next slide. Thank you. He then had a pericardiocentesis done with 2.4 liters of cloudy red fluid drained. The WBC was elevated at over 16,000, of which 75% were neutrophils. The glucose was very low and the protein was high. On gram stain, there was 4+ WBC and RBC, with no bacteria or fungal element seen, and it was smear negative for AFB. He was initially started on ASA and colchicine by cardiology, and post-cardiocentesis was already feeling much better. The next day, the culture was updated, and the patient was found to have 1+ lactose fermenting GNB. So, based on all of the information so far, I have a little multiple choice question. Do you guys think this could be TB? This is a misidentification, Q fever, an enterogram negative, or do you have other thoughts as to what it could be? And again, you can type in the chat or unmute yourself. Okay, we can move on. So here's a little more information that I found out about the patient on further history. He has prescribed Cadian capsules, and he sometimes buys them off the street as well, breaks them apart, and then injects the powder inside. He does clean his skin with alcohol wipes and injects with sterile water, but does not boil or heat the drugs. He always uses a clean needle and draws his drugs up through a new cigarette filter paper or the cotton from Q-tips. Does this information add to anyone's differential or change what they think it could be? If not, we can move on. So acute pericarditis can be caused by a variety of etiologies, as you all know, including viral, bacterial, and fungal infections, connective tissue disorders, malignancy, radiation, cardiac injury, and uremia. In the majority of cases, the cause isn't evident, and they're often deemed to be idiopathic, although many of these are thought to be due to a recent viral infection that's no longer detectable on testing. Purulent pericarditis is rare and accounts for less than 1% of all cases of pericarditis. Risk factors include immunosuppression, malignancy, a pre-existing pericardial effusion, chest trauma, and intrathoracic surgery. It's defined as local infection of the pericardial space with either gross purulent fluid in the pericardium or over 20 WBCs per field. Purulent pericarditis is usually a secondary infection from contiguous spread from an intrathoracic infection, such as from a pulmonary, myocardial, or peridiaphragmatic infection, or can be from hematologous spread. Direct extension from pneumonia or an empyema are the most common causes, and primary infection is quite rare. In terms of the clinical presentation, almost all patients are febrile. Only 25 to 37% of patients have chest pain, which can be non-pleuritic. Pericardial friction rub and pulsus paradoxus are found in less than half of cases, and 44 to 72% of patients either present with or subsequently develop cardiac tamponade. On investigations, most patients have a high white count and CRP, and about half have an elevated troponin. Chest X-ray, similar to our case, often shows cardiomegaly with an abnormal cardiac silhouette, which can also be associated with pulmonary infiltrates, pleural effusions, and/or mediastinal widening. The usual acute pericarditis ECG findings of diffuse ST elevation and PR depression are seen in most patients. Echo is the most sensitive test, however, it doesn't differentiate purulent fluid from other causes. Lastly, the pericardial fluid usually has a high protein, a glucose of less than 2, and a white count of 6,000 to 240,000. Purulent pericarditis is typically a monomicrobial infection. In terms of causative organisms, gram-positive bacteria account for 40 to 45% of cases, with Staph aureus being the most common organism, causing 22 to 31% of cases. Strep pneumoniae is the most common cause from contiguous spread, and TB is the most common cause of subacute or chronic purulent pericarditis in resource-limited countries. Other less common causes include fungal infections, Salmonella, Campylobacter, and other gram-negative bacilli like E. coli. Fungal pericarditis is becoming more common, accounting for 19% of cases in one case series, and these patients have the usual risk factors for candidemia. Purulent pericarditis should be treated with a combination of pericardial drainage and antibiotics. The pericardial drainage can be done via pericardiocentesis, subxiphoid pericardiotomy, or pericardiectomy. Pericardiocentesis is the easiest and fastest way to drain the pericardial space, however can be difficult as the thick fluid can have loculations and be difficult to drain. A pericardial window allows for a more complete and permanent drainage because of manual lysis of adhesions and loculations, and was recommended as the preferred method in the 2015 European Society of Cardiology guidelines. The final method is pericardiectomy, which has the highest morbidity and mortality, however, is sometimes necessary in patients who develop recurrent tamponade, persistent infection, or progress to constriction. Patients are typically treated with 2 to 4 weeks of antibiotics. Purulent pericarditis is associated with a high mortality of 20 to 40% and is frequently not identified until autopsy. Mortality in these cases is typically caused by cardiac tamponade, constriction, or sepsis. The patient in this case, gram stain, showed lactose-fermenting gram-negative bacilli. So this is just a quick reminder of which organisms include down in this red box. So you can see that this includes E. coli, Citrobacter, Klebsiella, Enterobacter, and Serratia. When I went to review the literature on gram-negative purulent pericarditis, there's really only a handful of case reports. E. coli is the most common gram-negative, and there were cases associated with perihepatic abscess rupture and immunocompromised patients with lymphoma, and someone in who had an underlying germ cell tumor who was admitted with an empyema. There was 2 cases of Citrobacter, one of which was Citrobacter frendii in a patient with an empyema, and another case was a patient with diabetes who had both Proteus and Citrobacter. Looking at Klebsiella, there were several cases, including a 24-year-old male on dialysis with alcoholic hepatitis, who was actually thought to have a primary ESBL pneumonia pericarditis. And in terms of Enterobacter, there was actually only 1 case of an 82-year-old male with rheumatoid arthritis as his underlying risk factor. I didn't find any cases caused by Serratia. Overall, gram-negative purulent pericarditis is quite rare and is associated with a variety of ages, comorbidities, and risk factors. In these cases, most patients were treated for between 2 to 4 weeks, often with IV antibiotics initially, and some patients subsequently transitioned to oral antibiotics to complete treatment. So going back to our case, I wondered if his GNB could be Pantea agglomerans, which is a gram-negative aerobic bacillus in the Enterobacteriaceae family and is associated with plants. It can cause soft tissue infections after penetrating trauma by a plant thorn, wood splinter, or other plant materials. It can also less commonly cause endophthalmitis, endocarditis, and osteomyelitis. There have been some rare cases of P. agglomerans bacteremia associated with contaminated IV fluids, TPN, and propofol. It does have a low virulence and is easily treated, typically with ceftazidime, piptazo, cipro, or aminoglycosides. And it's associated with cotton fever. As some of you may know, cotton fever is an entity that is well described among patient and community groups, but actually isn't well described in the medical literature. It's thought to be a benign, self-limited febrile response that can occur when cotton is used to filter drugs prior to injection drug use. Patients typically present with fevers, chills, leukocytosis, tachycardia, and can also get myalgias, abdominal pain, nausea and vomiting, shortness of breath, and headache. Symptom onset is typically 15 to 30 minutes post-injection and typically lasts 6 to 12 hours, however, has been reported to continue for up to 48 hours. And it is a diagnosis of exclusion, but I think something to keep in the back of our minds when patients who inject drugs come in with febrile illnesses and end up having negative cultures that are, so their presentation is unexplained. The pathophysiology of cotton fever is poorly understood, but there are 3 theories that have been proposed. The first is the pharmacologic theory, which is that cotton extracts contain water-soluble, steam-labile substances with pyrogenic activity. The next is the immunologic theory, which is that people have antibodies to cotton itself. However, no evidence for these 2 theories has actually been found. The final theory is the endotoxin theory, which is that it is caused by the release of endotoxins from GNB, such as Pantea agglomerans, which is known to regularly colonize cotton. And supporting this, a case of cotton fever has been described in a patient with P. agglomerans bacteremia. Coming back to our case though, the pericardial fluid ended up growing Klebsiella oxytosa, and their blood cultures were negative. His CT abdo-pelvis showed mild splenomegaly and mild to moderate prostatomegaly, but was otherwise unremarkable. In the end, I suspect that the source of his infection was likely a transient bacteremia in the setting of his IV drug use. When I looked into the literature, the only case of purulent pericarditis caused by the species actually was not in humans, but rather reported in 2 lions. In terms of treatment, he had initially been treated with ceftriaxone, metronidazole, and cipro, but once his cultures came back, he was transitioned to levofloxacin to complete 4 weeks of treatment. Oh, sorry. Perfect. The third patient is an alarming case. The 62-year-old female presented to hospital with left arm pain, swelling, and erythema. Her past medical history was significant for type 2 diabetes, hypertension, and dyslipidemia. In terms of her social history, she lives with her husband, she works as a teacher, and does not smoke, drink alcohol, or use recreational drugs. She reports that she was stung by a bee on her left arm 3 days prior, and then went to a walk-in clinic and was started on Keflex 2 days prior. She presented to hospital due to progressive pain, swelling, and erythema, as well as a new fever. On exam, she was febrile with a temperature of 38.2, and her vitals were otherwise stable. Her left arm was diffusely swollen, erythematous, warm to touch, and moderately painful on palpation, and there was no obvious wound on her arm. On blood work, she had a slightly elevated white count of 12.5, her CRP was elevated at 125, and her blood cultures were negative. She was initially started on cefazolin, but after having progression of her infection, despite several days of antibiotics, she was then transitioned to vancomycin in case of undiagnosed MRSA. However, despite this, her infection continued to progress and she remained febrile. Imaging of the arm did not demonstrate any underlying collections. Over time, she eventually developed new paresthesia in her arm in the setting of what clinically appeared to be in keeping with compartment syndrome, and so she was taken to the OR for debridement. Does anyone have any thoughts as to what this could be? If not, we can move on. Intra-op, she was noted to have fluffy white substance on her tissue, and the culture was positive for mucor. She was initially started on liposomal amphotericin B and then was later transitioned to isovuconazole. It was a quite aggressive infection, and she did require several ORs for repeat debridements. Mucormycosis is an invasive fungal disease caused by fungi in the order of Mucorales. These organisms are ubiquitous in the environment, and the most common pathogens are Rhizopus, Mucor, and Rhizomucor. As you can see on the image on the right, the hyphae are broad, irregularly branched, and have few septations. Risk factor include diabetes, especially if they have poorly controlled diabetes or DKA, treatment with steroids, hematological malignancy, stem cell or solid organ transplants, iron overload, trauma, or burns. Cutaneous mucormycosis is the most common form in immunocompetent patients. This often happens after skin disruption from trauma, surgery, or burns. It often appears as single, painful, indurated area of cellulitis that can then develop into an ecthyma-like lesion and then progresses to necrosis. Rhino-orbital cerebral disease is more common in patients with diabetes. They typically initially present with fever, nasal congestion and discharge, a headache and sinus pain, and can later develop palate necrosis, perinasal swelling, eschar in the nasal mucosa or palate, and cranial nerve involvement. Orbital involvement can present with periorbital edema, proptosis, decreased vision, and ophthalmoplegia. Pulmonary mucormycosis is caused by an inhalation of spores and is typically seen in patients with neutropenia or graft versus host disease, and it can spread contiguously to other organs. The classic finding is a reverse halo sign on CT chest. Lastly, you can get primary GI disease, which is overall quite rare, but is the most common manifestation in neonates. Overall, almost all of these patients do have fevers, and it's associated with an extremely high mortality rate of 40 to 80%. And so it's really important, especially in patients with risk factors, to have this on the differential and kind of be thinking about it in the back of your head. So in terms of the diagnosis, it can be diagnosed via ID of organisms and tissue by histopathology with culture confirmation. And on imaging below, these are pictures of the reverse halo sign. But it is important to assess the patient's clinical status as a mucor can actually be found in the setting of colonization or contamination and doesn't always represent a true infection. The most important thing to do in these cases is urgent surgical debridement. In terms of antifungal treatment, we typically start with liposomal amphotericin B. However, if a patient has significant renal dysfunction, you can start off with isobuconazole or posaconazole. If the patient is stable or you get partial response, you can either continue the liposomal amphotericin B or switch to one of the oral medications, so isobuconazole or posa. If the disease is progressive, regardless of which treatment you started with, you would switch to another regimen. And unfortunately, toxicity with amphotericin B is quite common. And so in that case, you can switch right away to isobuconazole or posaconazole. Just a quick note on isobuconazole. So this is a newer relative of voriconazole that's used for both aspergillosis and mucormycosis and has high oral bioavailability. What's nice about it is that it doesn't require any drug monitoring and does have a lower incidence of side effects such as hepatotoxicity, visual symptoms, and QTc prolongation. It tends to be better tolerated and have lower drug discontinue rates than some of the other azoles. In terms of treatment duration, the optimal duration is unknown, but patients are typically treated for anywhere between weeks and months. If patients have an underlying immune deficit that resolves over time, then it's recommended to continue until resolution of clinical and radiographic signs of infection. Okay, so the fourth and final case is a deep-seated problem. The patient is a 74-year-old male who was admitted with a large left gluteal abscess. He had a past medical history significant for COPD, sarcoidosis, and a mitral valve replacement. In terms of his social history, he lives on a farm with his wife, quit smoking many years ago, drinks alcohol socially, and does not use recreational drugs. He presented to hospital with a 3-week history of left hip and buttock pain that was so severe that he was newly requiring a cane to help with ambulation. He had also developed subjective fevers and occasional night sweats. He had no recent trauma to the hip. On exam, he was afebrile and en room air, but was tachycardic and hypotensive on presentation secondary to rapid AFib. He was found to have a large, tense collection overlying his left buttock. In terms of investigations, he had an elevated white count of 18.5, mild anemia with a hemoglobin of 110, and normal platelets. He initially had an ultrasound done of his left hip that showed a large, thick-walled fluid collection in his left buttock with significant echogenicity, and the collection appeared to communicate with the hip joint. He then had a CT, which showed a large multiloculated collection in his left thigh that extended to the gluteal muscle with peripheral rim enhancement and septae. The collection was 16.5 by 14.5 by 20 centimeters, and this time did not show any communication with the hip joint. In terms of microbiology, his blood cultures were negative. He had a bedside fluid aspirate done, and the gram stain showed beaded, branching bacilli that were modified acid-fast stain positive, and the culture grew nocardia species. His mycobacterial fluid culture was negative for AFB, but subsequently grew nocardia farcinica after 2 days. Going back to his review of symptoms, he did not have any respiratory or neurological symptoms and had no other skin or soft tissue involvement. His chest x-ray just showed chronic findings consistent with his history of sarcoidosis, but no acute changes, and CT head was unremarkable. He was not found to be immunosuppressed, Although he had been on prednisone for 14 years, he had been off it for over 20. His HIV serology was negative, A1C was normal, and he had normal immunoglobulin levels and SPEP. In terms of management, he had a drain inserted into the collection, which drained copious amounts of rust-colored purulent drainage. He had initially been started on vancomycin by Emerge and was subsequently switched to Septra and imipenem. So this is an overview of nocardia, which is a branching, beaded, filamentous, aerobic gram-positive bacillus that stains weakly acid-fast, and on the right you have pictures of it. It is ubiquitous in the environment and can be found in soil, organic matter, and water. It's typically acquired through inhalation or percutaneous inoculation, and there are over 50 species that have been identified. It's most commonly seen in immunocompromised patients, including those with chronic steroid and other immunosuppressive drug use, HIV, malignancy, and history of transplant. It can present as pulmonary, CNS, cutaneous, or a disseminated disease. Nocardia often presents subacutely, and disseminated disease is common in immunocompromised patients. Pulmonary disease is the most common primary site, and patients can present with fever, cough, night sweats, weight loss, hemoptysis, shortness of breath, and pleuritic chest pain. They can also develop an empyema, mediastinitis, pericarditis, or even SVC syndrome. On imaging, nodules are most commonly seen, but you can also get cavitary disease or ground glass opacities. CNS is the most common site of dissemination, so it's important to always do neuroimaging. Patients can present with acute or subacute focal neurological deficits, headaches, altered mental status, seizures, and ataxia. Interestingly, these patients often don't have a fever and can even be asymptomatic. On imaging, they can have a single or multiple brain abscesses, which present as ring-enhancing lesions with surrounding edema. Around a third of patients with nocardia are immunocompetent, and most of these patients have other risk factors such as chronic lung disease, diabetes, or alcohol use disorder. About half of immunocompetent patients present with pulmonary disease, and in one case series, all of the patients had underlying lung disease. These patients do have lower mortality rates. Looking into, sorry, you can go to the next slide. Thanks. Looking at nocardia furcinica specifically, it accounts for anywhere between 5 to 20% in the literature. It does seem to be more associated with cutaneous and soft tissue disease than other species. In a review of cases of primary cutaneous and furcinica, only 2 of the patients were immunocompetent, most presented with thigh abscesses, and most had a history of working outdoors. It's typically resistant to third-generation cephalosporins and most aminoglycosides, and is usually susceptible to amikacin, linezolid, Cipro, imipenem, and Septra. Lastly, I'll talk about cutaneous nocardia. Primary cutaneous infection is usually caused by penetrating trauma from a contaminated object or exposure of a pre-existing wound to contaminated soil or water, and patients can also get secondary cutaneous nocardia from disseminated disease. There are 3 forms of it: localized, nodular lymphangitis, and mycetoma. The localized infection presents as progressive, painful skin lesions, usually at the site of injury or a pre-existing wound, and often presents as nodules or ulcerations. Nodular lymphangitis is also known as sporotrichoid nocardiosis due to its similar presentation to sporotrichosis. This presents as a nodular or ulcerative primary lesion on an extremity with linear progression of erythematous nodules proximally. A mycetoma presents as a chronic infection that begins with painless, slowly growing indurated nodules that later coalesce to form large masses and necrotic abscesses with draining sinus tracts. Treatment usually includes Septra. If patients have severe pulmonary infection, then 2 antibiotics should be used, and if they have CNS or multi-organ involvement, then Septra, imipenem, and amikacin should be used. In terms of duration, patients should be treated for 6 to 12 months if they have a mycetoma, 3 to 6 months if they have other cutaneous diseases and are immunocompetent, and at least 12 months if they're immunocompromised. Thank you for listening to my presentation. Does anyone have any thoughts or questions? If not, then we're done a little bit early.
Thanks, everyone. Thanks, Danielle. That was great. And those were fantastic cases. If people have questions, feel free to just email Danielle if you think of them later today. Thanks, everyone.